Good day, friends. So here's to the management of type 2 diabetes mellitus based on the new 2026 NICE guidelines. What to use in type 2 diabetes mellitus? So we have seen a patient and he wants medicines. What should you give? Earlier we used to start the patient on metformin alone, but now we have to take into consideration about the cardio-renal protection because preventing complication matters most in type 2 diabetes mellitus now rather than checking the HbA1c levels. So what we use now is that earlier we used to give metformin, but now we have to add an early SGLT2 inhibitors like the gliflozins. So why is this change? Before asking this question, we have to start thinking what kills a diabetic patient. A diabetic patient just does not die because he has high blood sugars or he has high HbA1c. He dies because he has major risk factors like cardiovascular disease, heart failure, and kidney disease. So, because of this, we start the patient on SGLT2 inhibitors. But there are certain limitations. The limitation is that SGLT2 inhibitors can't be used in an elderly with the risk of fall, can't be used in orthostatic hypertension, and can't be used in patients with dehydration risk because of loss of water. Another complication of SGLT2 inhibitors is the euglycemic diabetic ketoacidosis. That means when a patient is on SGLT2 inhibitors, he will have glucoseuria. So the glucose levels in these patients will be either low or it will be normal. So there will not be any insulin production. And since insulin is not produced, it activates hormone sensitive lipase. Hormone sensitive lipase causes production of free fatty acids. This free fatty acids in the liver forms acetyl-CoA, and acetyl-CoA requires oxaloacetate to perform the Krebs cycle, but oxaloacetate is not there because it enters gluconeogenesis. So excess acetyl-CoA is left out and it enters the liver mitochondria and forms ketone bodies. So that's it, folks.